Today we're diving into a really critical area, especially if you're keen to understand the medications used in Parkinsonism. This is key stuff, particularly for, say, medical students getting to grips with neurology.
Absolutely. It's fundamental pharmacology.
We've pulled together a comprehensive guide focusing specifically on these drugs. Our mission, if you like, is to extract the most vital information, how they're used, how we classify them, how they actually work, their mechanisms.
And the important things to watch out for, the key considerations.
Exactly. We want to present it clearly, give you that solid grounding, covering those essential concepts relevant for clinical practice.
Okay, so let's start with the basics. Why are these drugs even used?
Good starting point. The guide outlines four main uses. First, and maybe the most obvious, is symptomatic control. We're talking about those core motor symptoms, tremor, rigidity or stiffness, bradykinesia, that slowness of movement.
And postural instability, the balance issues.
Right. The main goal here is just making daily life more manageable by easing those specific symptoms.
Precisely. Addressing these directly can make a huge difference to a patient's ability to function day to day.
Then there's this other kind of intriguing area, neuroprotection.
Ah, yes, the idea of actually slowing the disease progression.
Exactly. Certain drugs, MAOB inhibitors, some dopamine agonists, they're being looked at for potentially doing more than just symptom relief.
It's a very active research area. The evidence is, well, it's still evolving, but the hope is for real long-term benefits beyond just managing symptoms.
The third big use is managing motor complications. Later in the disease, things can get tricky.
You mean like wearing off?
Yeah, where the medication effect just fades before the next dose is due. Or the opposite problem, sometimes dyskinesias, those involuntary movements.
Which can be really disruptive.
Definitely. And that's where drugs like COMT inhibitors or mantidine come in. They help smooth out those fluctuations or manage the dyskinesias.
Managing these complications is a huge part of long-term care.
And finally, it's not just about movement. These meds can also help with non-motor symptoms.
Right. Things like depression, sometimes psychosis, even autonomic problems.
Like blood pressure issues or digestion. So it's a broader picture.
It really is a comprehensive approach. Parkinson's affects so much,
Yeah.
and the treatments reflect that.
Okay, so let's unpack the different types, the classifications. The guide gives us a good framework. First up, levodopa combinations.
The big one.
The main one being levodopa-carbidopa. You'll see brands like Syndopa, Cinnamate here. Levodopa is really seen as the gold standard, isn't it?
Absolutely. It's a cornerstone. And the carbidopa part is crucial. It basically stops the levodopa being broken down in the body.
Before it gets to the brain, right?
Exactly. So more levodopa reaches the brain where it's needed, and you get fewer side effects like nausea elsewhere. Think of carbidopa as its bodyguard.
Good analogy. Okay, next, dopamine agonists. Examples like pramipexole, ropinirole, maybe Parkin, Ropark are common brand names. The guide notes pramipexole is a non-ergot agonist. Why is that important?
Well, the older ergot-derived ones had more issues with fibrotic reactions like heart valve problems. The non-ergots, like pramipexole, generally avoid those specific risks.
Okay, good to know. And how do these work compared to levodopa?
They directly stimulate dopamine receptors in the brain. They sort of mimic dopamine's action, often used earlier on, especially in younger patients, or added to levodopa later.
Got it. Then MAOB inhibitors, selegiline, razagiline Celgin, Azilect perhaps. We mentioned these under neuroprotection.
Right. They work by blocking an enzyme, MAOB, that breaks down dopamine in the brain.
So more dopamine hangs around.
Essentially, yes. Increases the dopamine available at the synapse, making its effect last longer.
Okay. Next category, COMT inhibitors, entacapone and tolcapone. Brands like Contan, Tasmar. The guide highlights entacapone is usually used with levodopa.
Yes, it's an adjunct. COMT is another enzyme that breaks down levodopa, but mainly outside the brain, in the periphery.
So blocking COMT means more levodopa survives to cross into the brain.
Exactly. It helps prolong levodopa's effect, often used to combat that wearing off.
Makes sense. Then we have anticholinergics. Trihexyphenidyl is the main example, like Pacitane or Artane.
These work on a different neurotransmitter system, acetylcholine. In Parkinson's, with less dopamine, you get a relative excess of acetylcholine activity.
Ah, so these drugs block acetylcholine to restore the balance.
Pretty much. They block muscarinic receptors. They tend to be more helpful for tremor, but can have more side effects, especially cognitive ones in older people.
Okay, next, amantadine. It's listed as an NMDA antagonist. Brands like Symmetrol, Amantrol. The interesting note here is its role in reducing dyskinesias.
Yeah, amantidine's mechanism is a bit complex. It affects glutamate signaling via NMDA receptors, but also seems to boost dopamine release and block its reuptake.
So multiple
Right,
actions.
and that ability to help with dyskinesia is really valuable, particularly later on.
And finally, a newer class, adenosine A2A antagonists, estradiol, brand name Neuriast.
These work differently again. They block specific adenosine receptors, the A2A type, in the striatum.
And that helps dopamine signaling somehow.
Yes, blocking those adenosine receptors indirectly enhances the effects of dopamine signaling pathways. It's another add-on therapy, usually with levodopa.
Wow, okay. Quite a range of drug classes there.
Definitely. Each targeting the underlying problem or its consequences in slightly different ways.
Right, so now we have the what? Let's get into the mechanisms of action in more detail. The guide helpfully breaks this down into 3 steps. Step 1 is all about boosting dopamine.
Which makes sense, right? Since Parkinson's is fundamentally about losing those dopamine-producing cells in the substantia nigra that project to the striatum.
So top of the list here is levodopa. How does it actually replenish dopamine?
Well, the clever part is levodopa can cross the blood-brain barrier. Dopamine itself can't.
Ah, okay.
Once levodopa gets into the brain, enzymes convert it into dopamine, directly replacing what's missing in the striatum.
And that's where carbidopa comes in again.
Precisely. Carbidopa inhibits the enzyme outside the brain that would otherwise convert levodopa to dopamine too early.
Reducing side effects and getting more levodopa to the target.
Exactly. Without it, you'd need much higher doses and have way more nausea, blood pressure drops, things like that, from dopamine acting elsewhere in the body.
Okay. Then the dopamine agonists like pramipexole, how is their action different?
They skip the conversion step, they go straight to the dopamine receptors in the striatum, specifically the D2 and D3 types, and activate them directly.
So they're like dopamine mimics.
Pretty much, yeah. They directly stimulate the pathways dopamine normally would.
And the last one in this dopamine boosting step, the MAOB inhibitors like selegiline.
Right. They block that MAOB enzyme inside the brain. Since MAOB normally breaks down dopamine,
Blocking it means dopamine sticks around longer.
exactly, increases the dopamine concentration in the synapse, prolongs its action.
Okay, that covers step 1, enhancing dopamine. Step 2 in the guide is about modulating other neurotransmitters, glutamate and acetylcholine.
Yeah, because the dopamine loss throws other systems out of balance too.
So first here is amantadine again. It's an NMDA receptor antagonist. What does that mean?
NMDA receptors respond to glutamate. In Parkinson's, there might be excessive glutamate activity, which can be harmful excitotoxicity. Amantadine helps dampen that down by blocking NMDA receptors.
But didn't we say it also affects dopamine?
Yes, that's the interesting part. It also seems to enhance dopamine release and maybe inhibit its reuptake a bit. So it's got this kind of dual benefit.
Tackling glutamate and boosting dopamine makes sense why it helps dyskinesia, maybe.
Potentially, yes.
Okay, then the anticholinergics, like trihexyphenidyl. We touched on this blocking muscarinic acetylcholine receptors.
Right. The idea is to correct that imbalance. Less dopamine means acetylcholine has a relatively stronger effect in the basal ganglia, that movement control center.
So blocking acetylcholine helps restore a more normal balance between the two systems.
That's the goal. Particularly helpful, as we said, for tremor and sometimes rigidity.
Okay, step 3, adjunctive therapies.
Ah.
These are the ones used with other meds, right?
Yeah, mainly to boost or stabilize the effects of levodopa.
Like the COMT inhibitors and tacopone. It inhibits the COMT enzyme. How does that help levodopa?
COMT breaks down levodopa in the periphery. By inhibiting it, entacapone allows more levodopa to reach the brain and extends its duration of action, its half-life.
Ah, so it helps make the levodopa effect last longer and be more consistent. Fights the wearing off.
Exactly. Helps achieve more stable dopamine levels in the brain.
And the last one here, the adenosine A2A antagonists like istradfylin, blocking adenosine receptors in the striatum. This indirectly modulates dopamine pathways, essentially enhancing dopaminergic signaling. It's another way to boost the overall dopamine effect.
Okay, that's a pretty thorough look at how they work. What about what happens to them in the body? Pharmacokinetics.
Right, how they're absorbed, distributed, metabolized, excreted. The guide has a table, but we can hit the highlights.
Let's do that. Levodopa, carbidopa, rapid onset, usually 30-60 minutes.
Yes, which is why it's good for quick symptom relief. Remember that peripheral metabolism is extensive for levodopa itself.
Hence the carbidopa. Exactly. And elimination is mainly via the kidneys.
Okay. Pramipexole, also fairly quick onset, 1-2 hours, metabolized by the liver, specifically CYP3A4, and then renal excretion.
That CYP3A4 point is important. means potential interactions with other drugs using that same pathway. You need to watch out for that.
Good point. Selegiline, similar onset, 1-2 hours. Also liver metabolism, but a different enzyme, CYP2B6, than renal excretion of metabolites.
Again, liver metabolism is key.
Entacapone, rapid onset within an hour. Liver metabolism too, but through glucuronidation and mostly biliary excretion, so out via bile.
That different route, biliary excretion, might be relevant if someone has kidney issues.
And amantadine, slower onset, maybe takes a couple of days, 48, 72 hours. And critically, a lot of it is excreted unchanged by the kidneys.
Yes, that's a very important kinetic point. It directly leads into a clinical pearl.
Which is?
The need for dose adjustment and renal impairment. Because it's cleared by the kidneys, if function is poor, the drug can build up.
Right. Speaking of clinical pearls, the guide has a few more. For levodopa, take it on an empty stomach.
Definitely. Protein in food interferes with its absorption from the gut. Taking it away from meals maximizes how much gets in. Crucial patient advice.
Okay. For entacone, it mentions harmless orange urine discoloration.
Yeah, good to warn patients about that so they don't panic. It's expected, totally benign. Helps with sticking to the medication.
And we already covered the amantadine pearl adjust dose in renal impairment.
Absolutely essential for safety.
Okay, inevitably, we need to talk about the downsides, adverse effects. Let's go by drug type again, levodopa itself.
Well, the big ones are the motor complications developing over time, especially dyskinesias, also nausea, particularly early on, and sometimes psychosis, hallucinations, generally related to dopamine excess.
And management involves maybe lowering the dose or adding something like a COMT inhibitor.
Yes, it's a balancing act, trying to control symptoms without causing too many side effects like dyskinesias, which can be really disabling themselves.
Dopamine agonists.
Key issue here is impulse control disorders, gambling, hypersexuality, compulsive shopping, that sort of thing. Also leg swelling, edema.
Why the impulse control issues?
Thought to be overstimulation of D2, D3 receptors involved in reward pathways. Management is tricky dose reduction, maybe switching drugs. But it needs careful monitoring and open discussion with patients and families because the consequences can be huge.
Definitely. MAOB inhibitors.
And cause insomnia sometimes. The big theoretical risk is hypertensive crisis with tyramine-rich foods, aged cheese, cured meats.
But less of a risk now.
Much less with the selective MAOB inhibitors compared to older non-selective ones, but patient awareness about diet is still prudent.
Anticholinergics, we know these.
Yep, classic anticholinergic effects. Dry mouth, constipation, blurred vision, urinary retention, and significantly, cognitive impairment, confusion, especially in the elderly.
So lowest effective dose is key.
Absolutely, particularly regarding the cognitive side effects.
And amantadine?
Two characteristic ones. Livedo reticularis, the purplish mottled skin rash, usually on the legs and ankle edema, swelling. Probably related to effects on blood vessels, usually needs discontinuation if severe or bothersome.
Okay. What about situations where you absolutely should not use these drugs? Contraindications.
Right. For anticholinergics, absolute contraindications are narrow-angle glaucoma and significant dementia or cognitive impairment.
And levodopa?
Malignant melanoma. There's a theoretical concern it could promote growth, so it's avoided.
Are there relative ones too, where you need to be cautious?
Yes. Dopamine agonists used cautiously if there's a history of psychosis or previous impulse control issues.
Because they could make it worse.
Exactly. And MAOB inhibitors are generally avoided with SSRI antidepressants because of the risk of serotonin syndrome.
Which is serious, right?
Potentially life-threatening, yes. So that combination is usually a no-go unless very carefully managed by specialists. Risk-benefit assessment is crucial in these relative contraindication scenarios.
And we mentioned interactions briefly. Levodopa absorption reduced by protein meals.
Reinforces that empty stomach rule.
Selegiline and tyramine, that potential hypertensive crisis, though rare.
Still worth knowing about.
And entacapone potentially increasing INR with warfarin.
Yes. Probably due to inhibiting CYP2C9, which metabolizes warfarin. Needs closer monitoring of blood clotting if a patient is on both. Understanding interactions is vital.
The guide includes an exam tip here, which seems very relevant for our audience, maybe the students listening. It's about the on-off phenomenon with levodopa.
Ah, yes, a really key concept in managing advanced Parkinson's. Patients fluctuate unpredictably between being on good symptom control and off symptoms returning, sometimes quite suddenly.
And the tip is about management.
Right. Strategies include using smaller, more frequent levodopa doses to try and keep levels more stable, or adding adjuncts like COMT inhibitors or MAOB inhibitors, or even a dopamine agonist. Managing on-off is a major clinical challenge.
Good tip. What about actual dosages? Any general guidelines?
The guide gives some starting points and typical maximums, but stressing individualization is key. For levodopa-carbidopa, maybe start 325 milligrams 3 times a day, maximum often around 2,050 milligrams 4 times daily.
Pramipexole.
Start very low, like 0.125 milligrams 3 times daily. Titrate up slowly based on response and tolerance. Max usually around 4.5 milligrams per day total.
Amantadine.
Often 100 milligrams twice daily, but always remembering that crucial dose reduction for kidney problems.
And entacapone.
Typically 200 milligrams taken with each levodopa dose. Max usually 1,600 milligrams per day, so 8 tablets. But again, these are just examples tailored to the patient.
Got it. There's a pediatric note too, basically. These drugs are rarely used in kids.
That's right. Except for very rare forms like juvenile Parkinsonism. Standard Parkinson's is overwhelmingly a disease of older adults.
Okay, nearly there. What about toxicity and managing it?
Important to recognize, levodopa overdose can cause severe dyskinesias, psychosis. Management involves reducing or holding the dose, maybe using an antipsychotic like quetiapine cautiously.
What about abrupt withdrawal?
That can trigger neuroleptic malignant syndrome, rigidity, high fever, autonomic instability. It's an emergency. Requires restarting the dopaminergic drug, supportive care, maybe dantrolene.
And serotonin syndrome from MAOB inhibitors plus SSRIs.
Yes, hyperthermia, tremor, confusion, rigidity. Needs immediate stopping of all serotonergic drugs and supportive care. Recognizing these syndromes is critical.
The guide also points out specific black box warnings.
Yes, the strongest warnings. Dopamine agonists have one for impulse control disorders.
We discussed those.
Tolcapone, that other COMT inhibitor, has one for liver toxicity, hepatotoxicity. Needs regular liver function monitoring.
That's why entacapone is often preferred now.
Generally, yes, it doesn't carry the same liver risk, and amantadine has a note about potential increased suicide risk in patients with depression.
Important safety flags for prescribers.
Absolutely.
And one last high-yield fact from the guide. Deep brain stimulation, DBS.
The surgical option.
Yeah.
For patients with advanced disease, especially those with refractory motor complications, bad on-off, or dyskinesias that aren't well controlled by meds anymore.
So it's an option when meds aren't quite cutting it.
For carefully selected patients, yes, it can be very effective.
Okay, so that brings us to the end of this deep dive. We've really covered a lot of ground on Parkinsonism medications.
We have. From the main classes, levodopa, agonists, inhibitors.
To how they work boosting dopamine, modulating other systems, acting as adjuncts.
We looked at their uses for motor and non-motor symptoms, how the body handles them, those crucial clinical pearls.
Potential side effects, when not to use them, interactions, dosing considerations, and even toxicity.
A solid understanding of all this is just fundamental for managing Parkinson's effectively. It's about improving symptoms and ultimately quality of life.
It really highlights the complexity, doesn't it, and the ongoing search for better treatments, perhaps even truly neuroprotective ones down the line.